Good morning. Welcome to the Omega Psi Phi Fraternity Incorporated Gamma Pi Chapter Health Initiative webinar. My name is Dr. Kevin Ford, and I'm the chair of the Health Initiative Committee. Each month from September to June, the Health Initiative Committee, whether we're doing in person or by webinar, we try to present a topic that affects our community. And today's topic is COPD. And we're more than happy to welcome a good friend of mine, Dr. Les Kingslow. Dr. Kingslow grew up in Montclair, New Jersey, my home state. He did his undergraduate studies at University of Virginia. He also had he did medical school at Howard University College of Medicine. He did his internal medicine residency and internship at the Medical College of Virginia. Dr. Kingslow did his pulmonary and critical care fellowship at George Washington University. He's worked in the Washington, D.C. metropolitan area for the last 30 some odd years. He's been the director of pulmonary services at Providence Hospital for over 15 years. He also currently sees patients in St. Thomas, Virgin Islands, and also is on staff at the University of Maryland pulmonary section here at the new hospital. And I'd just like to welcome Dr. Les Kingslow to give a presentation and have a discussion on pulmonary disease and COPD. Good morning, Dr. Kingslow.
Good morning, Dr. Ford. How are you?
I am well, and thank you for coming and participating today. And
thank you for having me. Thank you for having me. It's always good to see your face. Good to see you home.
That's right.
I'm from Orange, New Jersey, not Montclair.
Not Montclair. Okay, well, I messed up on that one.
That's all right. That's all right. That's all right. So yeah, we're going to talk about, do a deep dive on COPD. It's a topic that is always in the news. We have countless patients that we come across in our daily lives as physicians who suffer from this unfortunate disease. And I'm thankful that we've been able to interact as colleagues on many of these patients over the years and help to improve their life and improve their longevity. COPD is a disease that affects the lung tissue, obviously. It's characterized by persistent respiratory symptoms that influence airflow limitations and cause abnormalities with the lung tissue as well as the bronchial tubes. And it's usually characterized by exposure to noxious particles and noxious gases. And these are ubiquitous in our environment. It's defined by a reduction in our ability to move air when we breathe. And the gold standard in making the diagnosis is pulmonary function testing, which your doctor would have to order. And the doctor would have a technician have you breathe into a computer, and we measure your airflow. And if there is an obstruction, a paucity of airflow, a reduction in your airflow of 70%, a reduction of airflow such that your airflow is less than 70% predicted, then that is diagnostic for airflow obstruction or COPD. There are other diseases that can cause reduction in your airflow that the pulmonary function tests will help tease out. But when we see an FEV1 over FVC of less than 70%, that's a diagnostic. And then we use one of those parameters, the FEV1, to grade the severity of the disease from mild to moderate to severe.
So Dr. Kingslow, you talked about a few things here, okay? Yeah. I want to break it down a little bit further, all right? So you mentioned particulate pollution. What is that?
So Kev, so when you pull up to a stoplight, there's a car in front of you, and they press on the gas, and you see this plume of white smoke. Well, that white smoke is filled with particulate matter. And those particles are solid and liquid, and they're so voluminous that it obstructs your ability to see. And there's a variety of chemicals that form those particles, and that's the particulate matter that we're inhaling that causes injury into the lungs.
So that's what you mean by noxious gases?
Yeah, and they can be gases from pollutants or gas, and the pollutants can be in the form of things that we inhale consciously, like cigarette smoke, cigar smoke, marijuana smoke, or things that we inhale that are in the environments, like air pollutants, sulfur from coal burning companies, or nitrates from the car exhaust, or other particulate matter. And there's varying sizes of particles. There's large particles that we can inhale that our airways defense mechanisms alleviate because of mucus trapping those particles and us expectorating them, coughing them out. Then there's smaller particles that could seed the smaller airways and cause injury to the lung tissue. There's even microscopic particles that are so small that they can even transverse across the air sacs into the bloodstream, just like oxygen does, and circulate in our bloodstream to cause injury.
So the size matters, apparently, of what you're taking into your lungs.
Right. I mean, it depends on how large the particle is. If it's a large particle, we could probably protect ourselves, but the body's host defense mechanisms are only prepared to manage so many things. As we get to fine particles and ultrafine particles, those seed the smaller airways and cause airway injury, inflammation in particular.
Yeah. So you're saying so that's what the particles can, so these particles, what do they really do to your health? I mean, what are we talking about here?
So when we're exposed to all these things, they cause progressive inflammation in our airway. They can cause injury to the lung tissue. They can increase our risk for illness, disease, and potentially increase our risk for early morbidity and mortality.
Okay. So how common is COPD?
So it's relatively common. There's about 251 million cases of COPD worldwide, and that results in about 3 million deaths annually from COPD. And as it stands, prior to COVID, it was the third leading cause of death worldwide. Now it's the fourth leading cause of death. COVID has superseded it. Here in the United States, we see about 25 to 30 million cases of COPD annually, and that results in about 250,000 deaths from COPD. And again, here in the United States, it's the fourth leading cause of death. And when you break it down, that's about 44 deaths per 100,000 lives of men, and about 35 deaths per 100,000 lives of women. The difference arising because, again, tobacco being the number one culprit for COPD, more men smoke than women. So we'll see more deaths in that population, in that demographic. We see COPD most commonly in the southern states and in the industrial states, although it's universal throughout the country, but we see the highest rates in the Deep South and in the Rust Belt.
So this is pretty prevalent disease. And so, what's the cost to our society as far as COPD?
It's profound. I mean, financially, when you're looking at medical dollars, it costs the United States about $50 billion annually to manage this disease. And that accounts for about 20 million lost days of work from patients who suffer from this disease. There's about 1 million emergency visits annually because of COPD. And that doesn't account for the office visits to the hospital, to the doctor's office, nor urgent care visits. We're talking about strictly emergency room visits. And when you look at the top 4 inhalers that we use for COPD, that's about a $12 billion industry to big pharma.
Wow.
Mm-hmm.
So I know you mentioned tobacco, but who's really at risk for developing COPD?
So patients who have underlying lung disease are at the greatest risk for developing COPD. Those folks who had some insult to their lung tissue in the past, patients who have a history of long-term asthma can convert their asthma to chronic airflow obstruction and COPD. Those are the biggest groups. We do know that there's comorbidities and that COPD walks hand in hand with people with underlying cardiovascular disease because of the underlying tobacco risk that induces both these diseases. There is one disease entity that causes COPD that is a genetic transmitted disease called alpha-1 antitrypsin deficiency. It's a deficiency of an enzyme that we all produce, and that the enzyme helps to protect the architecture of the lung. And when it's produced in deficient amounts, that architecture of the lung gets destroyed prematurely. So those are the big risks that drive it.
How frequent do we see that in our community?
Alpha-1 antitrypsin deficiency, it's quite rare. I mean, I screen almost all my patients who have a classic appearance of that disease, which is a lower lobe predominance of emphysematous changes. So I screen all those patients for it. And in my 30 years of doing this, maybe I've had a handful of patients who've been diagnosed with it. We see it more commonly in people of European descent than of African descent.
Okay. So what really happens when patients smoke? How does that really, affect the airways and the lungs to cause COPD?
So when I'm faced with a new patient or a recurrent patient who's chronically exposing themselves to toxins that cause lung injury, I often pose this question. I say, sir, if my sink in this room was filled with agents that can cause injury to your body, would you go into that sink and wash your hands with the water that's in that sink? And they say, oh, of course not. That doesn't make any sense. And I say, well, every time you toke on a carbon producing agent, you're dipping a paintbrush in that same sink of water and you're painting the insides of your lungs with that agent. So what happens with COPD is that we get exposed to carbon products, hydrocarbons. And the most common form, obviously, is smoking tobacco, but it's also in the form of smoking marijuana or living in an environment where you're exposed to an open flame all the time. Say, for instance, you work in a restaurant and you're grilling all the time, or you live in an area where you cook over an open flame all the time. You're inhaling all these carbon products. These carbon products get into your lungs. They activate certain cells, macrophages, which are the cells that they stimulate. The macrophages release chemicals that cause a recruitment of other inflammatory cells into the environment. And those inflammatory cells release these enzymes that are called proteases. And these proteases induce inflammation and injury and destruction of the lung tissue. And they break down the matrix, the fibers, the cartilage that make up the lung, so that the bronchial tubes, the airways lose their resilience, lose their efficiency, lose their ability to stay open and stay patent. And as you can create more and more injury, those airways start to collapse on themselves, so that when you are asked to breathe and exhale, the airways obstruct, they close off, and they trap all the air behind that obstructed area, so that the patients can't unload the lungs, and they trap air and they get short of breath more easily.
Okay. I see patients who get COPD come into office, you're doing fine for a while, but then they deteriorate.
Right.
And so why does this happen?
Yeah, this is COPD is a chronic disease, chronic obstructive pulmonary disease. It's a disease that is unrelenting. It's a progressive disease. There's no cure for it. short of taking the patient's lung out and replacing it with someone else's lung. That's really the only cure for COPD. So what happens with these patients is they fall into this vicious downward cycle where they develop the injury to their lung tissue. They have an exacerbation of that emphysema where there's more inflammation, more destruction. They get weaker. They have less respiratory resilience because of that exacerbation. They then, as they come through that, they've lost lung function. They've lost functional capacity. They can't exercise as well as they used to. It influences some mental health issues because of depression and anxieties about their breathing. Then they recover, but then eventually they'll get another exacerbation and go through the same scenario as well. And it's this gradual sort of downward spiral of their lung function toward disability and need for supplemental oxygen, and then unfortunately premature death.
Okay. So this is definitely it can be a deadly disease. Doesn't necessarily have to be, but it can be.
It does. Again, there's various severity of the disease, but obviously once we start getting to the point where we have advanced disease needing supplemental oxygen, then our mortality risk is fairly heightened. We actually can use the breathing studies, the pulmonary function test, to sort of predict what our mortality risk is relative to our lung physiology.
Mm-hmm. Mm-hmm. Okay. So, so how do you interpret the deterioration of a patient? I mean, how do you assess that?
So, when we see our patients, we take a lengthy history and do a physical exam, and then we do a variety of tests to try to get a sense as to the gravity of the disease. We do a chest X-ray. We'll do pulmonary function tests that will also include an arterial blood gas to measure their oxygen level and their carbon dioxide level. We look at other blood parameters to assess their total body health. We look for comorbid diseases like cardiovascular disease, diabetes, things that we've mentioned already. We'll also oftentimes do CAT scans of the lungs to take a look at the lung parenchyma to get an idea as to the characteristics of the lung tissue and how advanced the disease is. And then depending on those, we decide what our treatment plan is. We want to, one, address their physical health and try to increase their exercise capacity. We make effort to try to reduce their degree of exacerbations, improve their quality of life and well-being by instituting treatment modalities that will help in those regards.
Okay. So we know smoking, but especially tobacco, it's a big risk factor. And, I know in my office, I talk about, trying to stop smoking, all the patients. But what things, can you talk a little bit more about smoking cessation? How do you stop smoking? It may help someone to stop today.
So obviously at the top of that list is never smoke.
Right.
And those of us who do smoke, we need to instill in our family members, our children, look, don't do what I do. And make sure that your next generation, the buck stops with you, the next generation just doesn't smoke. When we look at the literature, and we look at doing cold turkey tobacco cessation, the success rate is pretty low, unfortunately. Probably 5 out of every 100 people who try to go cold turkey can do it and quit lifelong. So with that, we institute other modalities that are pharmacologic that will help to curb the craving for smoking. And there's 3 products that are on the market today that many people are already familiar with. One is nicotine supplementation, where nicotine is the product that's in the cigarettes that make you want to smoke. You crave it, we become addicted to it. It's actually the most addictive agent that's available on the market. It's more addictive than crack. It's more addictive than alcohol. It's more addictive than heroin. The disadvantage is that it's addictive, but nicotine in and of itself doesn't cause COPD. Nicotine doesn't cause lung cancer. But they put the nicotine in tobacco products to make you a great consumer. You're going to always keep on coming back and buying those whatever Newports or whatever you're buying. So we give nicotine as a supplement to reduce your craving for the tobacco. And the nicotine can be supplemented in a variety of forms. You can take it in a inhaled form. You can take it in a chewing gum form. You can take it in a lozenge form or in a patch form. And using nicotine supplementation, either monotherapy with one type of form or combo therapy with two types of forms, carries with it about a 44 to 50% success rate in curbing the craving for tobacco. And people can get off the cigarettes with that. There's also Wellbutrin, which is a well-known antidepressant that helps to reduce our craving for tobacco by manipulating those nicotine receptors. And that added to the nicotine supplement will increase your success rate another 5 to 10%, although many times we'll use that as a monotherapy. And then there's Chantix, which has been on the market for 20 years now and has probably the best success rate with nicotine, with tobacco cessation. With a success rate of about 6 out of 10 people. The disadvantage of Chantix is there's a black box warning on it. It can increase your risk for anxiety. It can cause depression. There's concerns for potential cardiac events and suicidal ideations. So all that has to be explained when considering these treatment options. And patients have side effects from any and a variety of medications. They just need to be informed about the potential risks and pitfalls and be told to stop the medication if things arise. The changes that the side effects that Chantix might induce are reversible once you come off the medication. There's also, mental health issues that weigh in, and we often refer patients to psychologists and psychiatrists to help them alleviate their tobacco craving as well. And that's pretty much the modalities at hand available to us to help alleviate tobacco addiction.
One of the things I've had, you've had any experience, I've had a couple of patients who've actually undergone hypnosis and who have been successful, but you don't get a lot of patients that do that. I know, insurances don't pay for it. Right. And so, but that's just one other modality that I've had maybe a few people that have done it. So
yeah, and I've had experience with that as well. It's few and far between. I think if it was a more common modality available, we'd probably use it a lot more. I don't have any hypnotists that are in my wheelhouse, unfortunately.
I don't either, but they found them and it seemed to work. So, but that's one thing. But yes, the Chantix and the Wellbutrin, those are definitely medications I prescribed in my office. And just have to be careful with someone that may, like you said, with Chantix, may have had a history of depression, or even with the Wellbutrin, the history of seizure disorder. I think that's one of the big things you don't want to give those patients. But definitely, I think the best thing you said was don't start smoking.
There you go. Exactly.
Right? And so what we need to do is to really catch people early, right? It's the high schoolers, the college,
right?
Where you're finding that that's where they start, and those are my long-term smokers. When did you start smoking? They say, "Oh, I was 15, I was 16," right. And then all of a sudden you look up and they have 30 years of smoking in, right. And they're relatively still young. So that's a something we need to catch our high schoolers, early college students, right. To stop.
Yeah, you remember Joe Camel? About 20 years ago, they had a cartoon character, pushing Camel cigarettes, on
right.
billboards. And
right.
The intention was conscious. They were advertising directly toward the youth. Mm-hmm. Same thing with the vaping, where, they have these, bubble gum flavored vape and, cinnamon flavored vape, and mm-hmm. all of it intentional to try to get new clients as they move through, different age groups and different markets. These companies are in the business of making money, and they don't really give two hoots about your longevity and lifespan. So,
yeah. I have a question. Someone just text me, will the lung regenerate or repair itself once someone stops smoking?
so that's a great question. So unlike the liver and your skin and your nail beds, the lung, you have a certain number of cells in your lung. They maximize, shortly after your birth, and they begin to degenerate. But by the time you're 35, all of us are losing lung function as we age. But the rate of loss of lung function is exponentially greater if you smoke. Once we stop smoking, the rate of loss of lung function mirrors the rate of loss of lung function of people who never smoked, but it never, ever gets back up to where it used to be. We can improve some of the physiology of the lungs. We can use medications to alleviate the inflammation, the mucus production, the bronchospasm, but we're not going to reverse the loss of lung function once we've stopped.
Right. So our main thing is we're trying to, once you stop, is to prevent the deterioration. And so, you're not going to necessarily improve it, go back to where you were before, but you just try to prevent that down spiraling of your lung function.
Yeah, we want to decrease the deterioration, improve our overall health, improve our exercise capacitance, and all along address other comorbidities that might be in play.
Mm-hmm. Another question just came up. What if you don't inhale cigars? Okay. And so are you at higher risk?
So we all have to, it takes us back to about 25 years ago. We had a president who told us that he never inhaled. So a lot of us don't think that we're inhaling when we are. A lot of us think, I'm mouth breathing. When we breathe, we don't selectively breathe between in our nose only. We're breathing in our nose and our mouth, and we're not even conscious of that. So, I'll have nurses, that patient's a mouth breather. No, we're breathing through our nose and our mouth at all times. So even though you think you're not inhaling, if you're putting a cancer stick, if you're putting a cigarette or a cigar or a hookah or a joint or e-cigarette to your mouth, you're getting it in your lungs, period. So don't kid yourself. If you don't want to get exposed to tobacco products and appreciate the potential pitfalls that may endure, then do not expose yourself to tobacco products. And we, if our will is not strong enough to protect ourselves, then we have to find other things that drive us to protect ourselves. Maybe it's our wives, or maybe it's our children or our grandchildren, or some dreams that we aspire toward. Mm-hmm. But we have to find our own motivations to say, look, this is just not healthy for me. And even though I enjoy it, even though I get some satisfaction out of it, it's part of my flow. It's, with the fellas, I like the way it tastes. All that being weighed, we've got to weigh that against the potential down the road. Well, honey, I'm sorry, I got a cancer on my tongue because I smoked for the last 25 years. Or honey, I got a big mass in my chest and they tell me there's nothing that they can do for me.
Right. Right. So. Right. I'm looking at the long-term effects.
Right.
Right. And also one of the things you even mentioned too, not only COPD, but tobacco is increased risk for developing heart disease, coronary artery disease, developing strokes, what we call peripheral artery disease with arteries. It causes clogging of arteries, right? Mm-hmm. Will put you at risk for so many other things. So not only just COPD, but all the other things that tobacco can do. And that's something that we need to be conscious of.
And we failed to mention, but tobacco, when Philip Morris, rolls these cigarettes, they're not, they're not just putting tobacco in those cigarettes. They're putting all those other chemicals that they splice with the tobacco in those cigarettes. They're putting in about 200 different chemicals in the cigarettes, all of which are identified as carcinogens. So we have like formaldehyde, embalming fluid. We have toluene, we have benzene, we have cadmium. All these heavy metals are dumped on top of those nicotine leaves that are rolled in those cigars and those cigarettes, and they, on top of the carbon that you're burning and inhaling, are all potential carcinogens to increase the risk for cancer from your nose, from your brain down to your Johnson. So you don't want to expose yourself to those with any.
So people that have COPD, if they get sick from all the different respiratory illnesses that are out here, I think they do a lot worse. And so are there certain vaccines that you recommend for patients who have COPD that they should get?
Good question. So to preface that, we recognize that because of the injury that the tobacco products induce in the lung tissue, your lungs are already inflamed. So you're already predisposed to having progressive decline in lung function. You add on top of that a germ that will potentially tip patients over into a chronic bronchitic scenario, acute exacerbation, a hospitalization, respiratory distress. So we do preventive measures to try to preclude these scenarios. And part of that preventive regimen is vaccination. So with patients with lung disease, we prematurely give them 2 vaccines early, and that is the Pneumovax and the Prevnar 20. These are both vaccines that are targeted toward pneumococcal pneumonia, which is the most common bacterial trigger for pneumonia. So the standard is with patients who don't have lung disease that we get the Prevnar 20 at age 65, the Pneumovax at 66. But if you have underlying lung disease, then we want these patients to be vaccinated earlier because we know that they're at a higher risk to get pneumococcal infections. So that's one. Flu vaccine. We know that we lose about 40,000 people annually to death because of the flu. And this is preventable as long as we vaccinate annually. So I typically tell my older patients I want them to sort of vaccinate with the flu a little later in the season so they can have more coverage as we extend out into the fall. But everyone should get vaccinated against the flu, in particular those patients who have underlying lung disease. We're in a pandemic, obviously. COVID-19 isn't going anywhere. We know that patients who contract COVID bronchitis, COVID pneumonia, they have increased propensity for morbidity and an increased propensity for mortality, although Omicron, the mortality rates are a little less than they were with the previous variants. With that said, we know that those patients who have underlying lung disease or other comorbidities, cardiovascular disease, diabetes, obesity, aged, these patients are at a much higher risk to have more advanced morbidity from COVID-19 and have an increased risk for long COVID. So we want patients to be up to date with their vaccine schedule with COVID. A lot of people think that they are, and when you interview them, you find that they haven't been vaccinated since last spring. We need to recognize that the prior vaccine for COVID, its ability to protect you wears off after about 5 to 8 months. So if you're vaccinated against COVID back in April, you don't have any protection now. So the most current new vaccine, the bivalent vaccine, protects against the current variants and the prior variants. It was just released in September. If you haven't had it, you need to get that one because the prior vaccines don't give you any coverage against Omicron. So those are much the main vaccines that we want to do. Shingles vaccine really doesn't have an influence on on COPD, but you should be vaccinated against shingles as well.
So should everyone that's ever smoked get screened for COPD?
So we consider patients who, haven't smoked so we grade your level of smoking based on pack years, the number of packs you smoke per day over the number of years that you smoked. And if you have less than 5 pack years of smoking and you're asymptomatic, there's really probably no need to screen for COPD. But as you advance beyond that, or if you're an active smoker, and if you present for any reason with respiratory issues, then by all means, you should get pulmonary function tests. And it's important to know, because even though you may have mild COPD, having that information in your armament will instruct you on how you're going to live your life potentially, and afford the doctor to advise you as to things you need to do to be preventative as it relates to potential pitfalls with your health moving forward.
Okay, great answer. So there's something, so people that have COPD, a lot of times they're having problems with shortness of breath or breathing difficulties. And there's something called pulmonary rehabilitation. Okay. What's the role in someone that has COPD? And then how is pulmonary rehabilitation, how does that differ from regular physical therapy?
So as we mentioned earlier, with patients with emphysema, they lose muscle function, they lose muscle mass, they become more weak and fatigued because and the term is deconditioned, because they can't exercise as well as they used to because they get short of breath. So about 25 years ago, there was the advent of pulmonary rehab, and how this differentiates from physical therapy is that it's the rehabilitation is driven by a therapist who's specifically trained to address patients with lung disease, as opposed to a general physical therapist who's doing body mechanics on all different muscle groups. These programs are specifically geared and tailored to address exercises that will help improve the lung compliance. And through that, the respiratory therapist is training the patient on how to exercise, what things to look out for, how to breathe, how to cough, how to splint their breathing, warning signs for exacerbations. It's monitored by an expert. It's covered by CMS, by Medicare, and most insurances. And it's a 36 visit program. So patients are going in 2 to 3 times a week for a total of 36 visits. Patients can be re-enrolled once they've completed the program after about 2 years. Most programs offer a maintenance program. What we find is in those motivated patients is that once they finish pulmonary rehab, they graduate on their own into their own exercise training program. So because they appreciate that they've gained significant amounts of muscle function and agility and resilience and conditioning, and it's improved their sense of well-being and their sense of breathlessness. I always tell my patients that your second heart are your thighs. That's the second biggest, the biggest muscle group in your body, and the second biggest pump in your body. So if we improve your leg muscles, we're going to improve your cardiovascular status. So that's really what pulmonary rehab does.
Excellent. I'm going to take a couple questions real quick from the chat. You had mentioned earlier about someone who works as a chef or grills foods can develop COPD from inhaling fumes from the grill. It says, how many years would it take to damage the lungs due to that?
So, there's no absolute answer. Everyone responds to toxins differently. The classic story is the guy's been grilling for 20 years. He's got an open flame. He's over these coals. I work in the Caribbean, so I see a lot of cats that are working over open flames as a rule, and they've been doing it for a protracted amount of times. We see them with lung injury. They come in short of breath. They've got emphysematous changes in their lungs. there's no way of predicting. If there's a concern, you need to get your lung function assessed. Um, you know, we have to think about, we all have to, generate an income, but we have to think about the potential occupational health hazards that may portend in those particular occupations. I have patients that come in, they're hairdressers, and they're exposing themselves to hairsprays for years and years, and they come in with lung injury. I've got patients who I have a patient who's a Native American who used to do all these exhibits where he's living the life, and he's in a teepee, and he's out on a range, and they've got folks coming through, and he's got an open flame in that teepee all the time. He did that for 15 years of his life, not every day, but he smoked on top of that. Now he's got lung injury, emphysema, and it's partially influenced by him being in a teepee with smoke smoldering, 8 hours a day, a few weeks out of the year.
Okay. So we talked about COPD, but what are the treatments? Are there any treatments that we can do?
So we mentioned pulmonary rehab as a non-pharmacologic treatment. Exercise training in any form is another non-pharmacologic treatment. There are other non-pharmacologic treatments that we reserve for patients who are at more extreme disease, like chest percussion therapy, the vest therapy. These are percussive devices that drum on the chest to help mobilize secretions, and there's data to show that's been efficacious in improving lung function. We always obviously vaccinate as a preventative measure. Nutrition is important. We see patients that have progressive disease, they lose not only muscle function, but their nutritional stores decline as well. So we always want to have them involved with nutritionists and to improve their nutrition status, because we know that optimal nutrition alleviates the excess work and burden on the muscles that help us breathe. As far as pharmacologic interventions are concerned, there's a number of them. The most common that people think of is, I need oxygen because I can't breathe. Well, you have to meet Medicare criteria guidelines to qualify for oxygen. Your oxygen level has to be significantly depressed before we can put you on supplemental oxygen. But usually that's often the first call that people say, I need more oxygen, when they walk in the office short of breath. We do use oxygen therapy in patients who have compromised oxygenation relative to the COPD. But again, that's used at the more extreme diseases. The more common approaches are using medications that bronchodilate the airways, relax the smooth muscle around the bronchial tubes to allow more airflow into the lungs. And they're in the form of beta agonists and anticholinergic therapies. And these work on two separate receptors in the airway to relax the airway and allow better air entry. When in patients with and we use those as monotherapy early on, but then as combination therapy as patients advance from mild to more moderate disease. As we get into moderate and trending toward more severe disease, then oftentimes we'll add an inhaled corticosteroid to decrease the inflammation in the airway as well. And typically we like to use these in combination with a single delivery system, as opposed to using 2 or 3 different inhalers. And the reason for that is when we compare the studies looking at patients taking 2 or 3 inhalers versus patients taking those 3 medications in 1 inhaler, the patients that take the monotherapy 3 in 1 typically do a lot better than those who are taking 3 different inhalers. And it speaks for itself. Obviously, compliance is a big concern. And that's probably why I think people do better. But the data is clear that there's a separation of curves between those different groups, and that patients on mono triple therapy with moderate to advanced disease do better. Other modalities that we use to treat COPD, we often use systemic steroids in the midst of exacerbations to decrease inflammation. That's prednisone or solumedrol. We typically try to use it in limiting forms, but some people can't come off the steroids. They need them for long-term survival, and we have to accept the potential pitfalls that those may portend. There's a relatively newer anti-inflammatory medication that we use. Good gracious, I just drew a blank on the name of the medication, but it's a once a day PDE4 agonist that we'll use for patients. We use and reserve that for roflumilast is the name of the medication. And then we have to resort in patients with even more advanced disease to more aggressive interventions beyond those medications and oxygen. And that would be external ventilators. You think of patients who have COPD and they're using a CPAP mask. Well, in COPD, we often will use a BiPAP mask to help prolong survival, help unload the work of breathing from the lungs and the patient to the machine to help them ventilate. We use the BiPAP at night and with exacerbations. I mentioned the vest, the chest percussion device that we'll use. And then there's surgical interventions that will engage patients who have advanced disease and significant air trapping. One is lung volume reduction surgery, where we'll literally remove, excuse me, those emphysematous blebs in the lung and allow the remaining lung to expand and function more efficiently, and this will prolong survival. We'll use valves in the bronchial tubes that will accomplish the same end as well. And there's a lot of research in that arena that has improved over the last decade. And then lastly, in patients who these other modalities are not salvaging the patients, if you meet criteria and you're of a certain age group, we will offer lung transplantation. And again, that's a modality that we'll use in patients we predict will not survive over the next 5 years with their COPD.
Okay. So one thing, Dr. Kingslow, someone wrote something about children. Have you seen any children ever get COPD?
There are children who have bullous lesions. These are ballooned areas of the lung that have no normal lung parenchymal apparatus in those ballooned areas, and those are rare, but we see that. There are children that are born with an atrophic lung, Swyer-James syndrome, where they're born with a lung that just never grew, and a lot of people, they'll have some airflow obstruction. It's not classic COPD. There are young adults who will convert from brittle asthma to COPD because their asthma has just been so inflamed and so obstructive that their asthma is a reversible airflow obstruction, where we'll take inhalers, we'll see an immediate reversal of their airflow. But some patients, because their asthma has been just so traumatic and injurious, they become obstructed, and their obstruction becomes irreversible versus a reversible patient who has conventional asthma. So there are young asthmatics who, in their 20s, their 30s may have a fixed airflow obstruction. But as far as classic COPD, no, we don't see that. I don't see that.
Okay, great. Let me get one more question. Secondhand cigarette smoke and being exposed to that. What's your risk as far as lung cancer, COPD?
So there's been a number of studies that have kind of looked at this question, and there's really no data to show that secondhand smoke increases your risk for lung cancer or emphysema. With that being said, if you are in environments where you're living in your high risk arena for lung injury, you're an urban dweller, you have occupational exposures, you want to do everything you can to mitigate your risk for having lung issues as you progress through your life. So, the rule of thumb in my household is no one smokes. And if you have smokers in your household, you have to impress upon them that they not only have a responsibility to themselves to protect their health but they also have a responsibility to you as their loved one. They have responsibility to the family finances, to the exchequer, to your promise to one another at the altar, to mitigate disease and risk. I'm saying this to you and reminding myself the things I need to do for my own healthcare. But the reality is that we all have a social contract that we sign to protect other loved ones and other community members from disease. And part of that is to mitigate our exposing them to secondhand smoke.
Okay. Well, one of the things I think we really talk almost time for our webinar, but can you go over as far as lung cancer?
Mm-hmm.
And when do we screen patients for lung cancer?
So that's a really hot topic, particularly over the last 5 years, 10 years or so. There was a large nationwide study that there's been a number of studies that have looked at this question of how to screen patients for lung cancer. And historically, the question was, well, do we use chest x-rays to screen patients for lung cancer? And what's the efficacy of that? And there was really no hard data, no convincing data that chest x-rays made any difference with identifying early lung cancers in patients who are considered at a higher risk for lung cancers. And then there was a pivotal study that came about 8 years ago or so, maybe a little longer than that, that looked at this question with smokers and the role of screening CAT scans of the lungs to predict for lung cancer. And what they showed was when they took thousands of patients who smoked and graded them relative to the number of pack years that they smoked, and then did CAT scans on these patients, they found that patients who smoked the equivalent of 1 pack per day for 20 years, so that would be a half a pack per day for 40 years or 2 packs a day for 10 years, the equivalent of 1 pack per day for 20 years. If we do CAT scans on those patients, there's an increased likelihood that we're going to improve survival by identifying early lung cancers. So the dogma is, and the insurances have approved us to do lung cancer screening in anyone who smoked the equivalent of 1 pack of cigarette per day for 20 years. So again, if you smoked 3 packs a day for 5 years or 2 packs a day for 10 years, you're still going to meet that criteria. Or if you smoked a half a pack a day for 40 years, you're going to meet that criteria. And all these patients require screening CAT scans, and not just one, but they need to be screened annually for 15 years after they finished their last cigarette. So if you quit smoking this year, you'll still need to be screened this year and every year thereafter for 15 years with a CAT scan to determine whether you have lung cancer. We stop at 15 years because the data reflects that once we've stopped smoking for 15 years, our risk for developing a lung cancer thereafter mirrors that of the general population, and we don't screen the general population for lung cancer.
Excellent, excellent. So, Dr. Kingslow, we covered a lot of information today in this hour. I really appreciate you coming on and giving us the knowledge about COPD, tobacco smoke, the particulate matters that affect the lungs, and hopefully the people who are on the webinar will take heed to the stopping smoking in all forms to help prevent themselves from developing COPD or eventually even lung cancer or other comorbidities. So I appreciate you, sir. And I think we answered almost all the questions in the chat, and we'll going to sign off now. One thing I want to note, as far as the Health Initiative Committee, we'll be doing a second webinar coming up in 2 weeks. And we have Brother Jadan Phillips, who's our 2nd District Health and Wellness chairman. He's going to be speaking on adult immunizations. So hopefully everyone will be able to tune in to that important topic also. And again, thank you for tuning in. And again, thank you, Dr. Kingslow.
Well, thank you for having me, Kevin. I'll talk to you soon. Hey,
All
great
right.
day.
Take care, sir.
Bye-bye.